So today's talk is going to be on Nf2 and auditory brainstem implant. And so I thought we'd review that topic under the neurotology. So Nf2 is defined, the NIH criteria came up in 1993. That criteria defined Nf2 as the hallmark with bilateral acoustic neuromas. It also left some room for first-degree relatives with Nf2. Now, since that time, there's been several different additional classification systems that have come out. There's the Manchester classification. There's been a couple other individuals who have published, but there's really been no consensus as far as saying that we're going to move past basically bilateral acoustic neuromas. There's some movement now to talk about that we may rename these Merlin deficit gene, based on the Merlin deficits, that may start to allow us to use genetic markers to identify this. But for the most part, I think everyone's still talking about Nf2, and again, the hallmark is the bilateral acoustic neuromas. The next slide, of course, kind of talks about the problem that we deal with. Now, as neurotologists, the main issue that we typically see, of course, is the acoustics. And the question is, when do you intervene for these patients? What is the intervention that should be done? The consequence, of course, of bilateral acoustic neuromas is that patients are going to have complete deafness and with brainstem compression, and these tumors can, of course, get quite large. With many times very good hearing, and that's the dilemma that comes up. One of the other problems that we see with these individuals is that many times there's no one individual that needs to take charge. So there really needs to be kind of a captain of the ship for these patients, because they tend to find many different disciplines that are treating them if just done as a just but also other cranial tumors, spinal tumors, peripheral nerve tumors. That can you want to have someone who's really kind of monitoring everything for these individuals. And in our clinic, we have now a multidisciplinary team that's doing that. But depending on where these patients are at, there should be somebody who's kind of taking the lead for them. The problem that we see is that, you can have these tumors. It can be just somebody will present with just small bilateral tumors, some medium-sized tumors, and some patients, quite interesting, will not present until they have very large tumors. And you can see this individual with a very large tumors, their brainstem's significantly compressed. This person was still up, walking around, with hearing in the ear. So they can actually get quite large before they can present. And I think it just has to do with the slow growth of the tumor over time and the adaptation that takes place as well as these tumors grow. Now, when we think about the tumors, and this is where we get into this incidence and prevalence question, but the incidence is that actually 1 in 40,000 live births will result in someone with Nf2. When you look at the general population, though, we usually talk about, obviously, acoustics are 1 in 100,000. But again, that's prevalence as opposed to the incidence. As looking at any type of ethnic or gender preferences, we really haven't seen any in all the studies that have been done. The average age of diagnosis is 22, and I think that's real important when we talk about this disease, especially when you start seeing individuals who are over the age of 30 or 40, and you see someone with bilateral acoustics. In my mind, anyone who presents over the age of 40 with bilateral IAC masses, you really need to rule out some type of carcinoma first. That being said, I've seen patients who have presented with mild Nf2 in their 70s with bilateral tumors with just mild hearing loss. So you can see this. There's also potentially other factors that can also produce bilateral tumors, such as a previous history of radiation therapy. I've seen that in individuals who have been presented with bilateral acoustics, meningiomas, and yet their Nf2 studies are completely negative. Now, maybe they're a mosaic, but then these are also a couple of individuals who have had previous radiation therapy for, tonsil dysfunction, adenoid dysfunction when they were kids, and they presented with bilateral acoustics when they were in their later years. So, but most patients' average age of diagnosis is 22. This is also why you'll see some literature that talks about any patient with a unilateral acoustic under the age of 25 must be considered to potentially have NF2. And these are individuals you really want to make sure that you have fine-cut IAC studies to look for the other side in anybody who's a young person, as opposed to just a brain MRI scan. I think, recognize that some of this is evolving, because some of these kind of dictums of, if they're under 25, they potentially have NF2 was done in the CT era, and that's kind of carried over in the literature, even though obviously now most of us would get an IAC study with fine cuts through the IC, but that's just something just to be aware of. Family history, about 50% of patients will have a family history and 50% are founders. Obviously, it's been located to the NF2 gene. Now, there is some phenotype-genotype correlation. So what you'll see with truncating mutations, you see a much more severe phenotype. These are typically the kids that will present a much younger age. We'll see NF2 many times in, children under the age of 2. Typically, those are real severe phenotypes, and many of them do not survive past early childhood. The splice site mutations can be real unpredictable. There's still a small group that is thought to have these missense mutations, and it's difficult sometimes to identify those unless you actually have the tumor specimen. So that's one of the things that we try to recommend, that if someone's going to have an NF2 patient that's going to have a tumor removed, that they consider having genetic analysis of that a tumor, especially if there's other family members, or if they have children, is something you want to think about. When we look at, again, the phenotype-genotype correlation, you will see these mild individuals. They tend to present a little bit later. These are the individuals that will just have potentially 2 vestibular schwannomas only. They may not have any other tumors. Those in the more severe category will have, multiple tumors, spinal tumors and everything. One of the things that we usually recommend for a patient who's early diagnosed is that they have what I call staging of NF2, and that means they get a complete head study and they get a complete spine study. And ideally, you want to have them obviously have their audiometric stuff done, but also have them see a geneticist as well, so they can talk about the genetic aspects of the disease. We had I was the PI of a Department of Defense natural history study that lasted for about 8 years. And so as part of that, we had an international consortium where we pulled about 13 different sites together across the world to look at the characteristics of NF2. What was interesting is that, again, as I mentioned, there was no gender differences between the two. Hearing loss really only presented about a third of the time as far as their diagnosis. So as otolaryngologists, we're only seeing the initial presentation about 1/3 of the time. If we look at the symptoms that they presented with, many of them were asymptomatic, and these were typically the family members that were screened because of someone that was diagnosed, or we'll see sometimes, as I'm sure some people have seen, you'll see an asymptomatic patient that's diagnosed because they had trauma or some other type of reason to have a head MRI scan or a spine MRI scan. And then, interesting enough, about 1/3 of them presented with central findings such as either headaches or ataxia. And so these typically presented to either the neurologist or the neurosurgery colleagues. This graph is a graph of showing the age of first presentation and then the age of diagnosis in 161 patients. And this is part of our consortium data that we obtained as well. Now, this was in the late 1990s, and I think some of this is still true today. And what it is it shows that in the average delay of diagnosis of Nf2 from the patient's first symptom was about 7 years. So many of these patients, for instance, would have a spine tumor that was removed, and then later MRI scan of the head shows bilateral acoustics, or they would start having symptoms, hearing loss, and for whatever reason just didn't go in until some period later. Hopefully we're doing a better job of educating people on evaluation of Nf2 to make sure that we actually think about Nf2 in individuals that present with symptoms. So one of the problems with Nf2 is that many of these patients have normal hearing. And so, as I mentioned, these tumors can get quite large before the hearing loss happens. And this goes back to a study that Fred Lithicum published early on. So these are schwannoma tumors, and Fred actually stained the cochlear nerve. And so the sporadic tumors, you tend to see the cochlear nerve tends to be on the periphery, whereas the Nf2 tends to be a little bit more infiltrative. And therefore it separates the nerve fibers as opposed to stretching them. And that may be why these individuals have hearing loss that persists despite the fact of getting very large tumors. Now, there's been some other work with this, and some people have some different theories about that, but in general, it's just interesting. You'll see very large tumors with very good hearing in Nf2 many times. As I mentioned, there's multiple different tumors we have to think about, and I think if we just get pigeonholed into thinking as neurotologists of just the acoustics, we really need to understand the entire disease if we're going to be making these different treatment decisions on the tumors. So the patients not only have the vestibular schwannomas, but they'll have meningiomas. Fifth nerve schwannomas are actually very common, and then other cranial nerve schwannomas are common. So the kind of in order of we see for schwannomas, we'll see the vestibular schwannomas as the most prevalent, followed by then usually fifth nerve tumors. Lower cranial nerve tumors will then follow, and then many times we'll see some intraorbital tumor, third nerve tumors, very common to see. The meningiomas can be just one or two, or you can see someone like this individual who just has multiple meningiomas. You can see that we've got a couple of very large ones here, but then the meninges are just completely filled with meningiomas. Now, one of the things I tell our fellows is that when you're dealing with a patient with Nf2, I think you have to be much more careful with the dura. And the reason for that is I think the dura can actually is much more sensitive to trauma. And therefore, what's interesting, if you look at patients who, for instance, have had a previous middle fossa or a retrosigmoid approach, many times what you'll see is that the dura will be thickened in that area, and sometimes they'll actually have a small meningioma in that area. So I think these individuals are just very, very susceptible to developing meningiomas from a variety of different inciting instances. So here's an example of a meningioma. And we can see this is probably in this patient had a retrosigmoid previously done in another institution. And you can see they've got a facial nerve schwannoma here, acoustic on the other side. But this meningioma here is probably the result of the retrosigmoid approach. And it's not that the surgeon did anything wrong. It's just that these individuals sometimes can just develop meningiomas just if the dura was traumatized. Like I said, it's interesting. I don't have a picture of this. I need to find one. And so maybe we can look for some of these previous middle fossa patients. Like I said, they'll get dural thickening where you actually lifted the middle fossa plate. So just have to think about that when you're dealing with an Nf2 patient. Here again, more multiple meningiomas that we see in another Nf2 patient. Now, the other thing that's interesting in Nf2 patients is that they can also get an ependymoma. So an ependymoma is typically seen in the cervical spine, and it's usually an intrinsic lesion of the central spine. Early on, we weren't quite sure what these were. They were, when the MRI scan was getting a little bit better in the 90s, when we started seeing these, we said, well, there's some sort of imaging abnormality here. Ependymomas are a common spine tumor. I don't know if it's a common spine tumor, but it's a spine tumor that's frequently seen. These spine tumors can many times grow and cause problems. What's interesting in Nf2 is the ependymomas in Nf2 tend to act a little differently, and that is that they rarely cause symptoms. So if you can envision, you've got an ependymoma that's in the middle of the spine, it starts swelling or growing, and if it grows, it can compress the spinal cord. Whereas with Nf2, these ependymomas typically are just, they're there. They many times do not change in size. Rarely they can, so they do need to be monitored. But most of the time they're just there. The reason I bring this up from the neurotology side is that you have to think about what's going on in the cervical spine. You could have a very large cervical spine tumor or ependymoma down there that may potentially influence what you're going to do intracranially with your vestibular schwannoma. So it's just something you have to be aware of, and that's why I say I think the patients need to have a full spine series upon their initial diagnosis. Lower cranial nerve tumors can be quite a problem for these individuals, and the reason for that is that they can present on both sides. We looked at the mortality factors from Nf2, and one of the things that was most predictive was the fact that patients who had bilateral lower cranial nerve tumors, if they lost bilateral lower cranial nerve function, tended to have a much greater morbidity and mortality, because obviously many of them became trach dependent, G-tube dependent, aspiration, pneumonia became a very big issue. And many of these patients try to avoid tracheotomy as long as possible. There's been some patients who have gone on to have laryngectomies because of their lower cranial nerve tumors, just from chronic aspiration as opposed to having a indwelling trach. They just said that was much more convenient for them than having to, like I said, deal with the trach and worry about aspiration issues. So this can be a significant reason for mortality in these patients. If we look at the incidence then of these other tumors with Nf2, meningiomas, so I've at least listed a couple different things here. One was other papers that have been published, then our natural history consortium looking at spine tumors. So somewhere around 60% of patients are going to have meningiomas. Anywhere from 60 to 90% are going to have spine tumors. Skin tumors are quite frequent. So if you ask these patients, many times they'll have a skin lesion somewhere in the somewhere in their on their body. If you don't ask, they won't tell. But these can sometimes be a problem. For instance, if it's on the hands, fingers, or face, sometimes they'll want to have those removed, either from a cosmetic or a functional perspective. The significance of that is that's an opportunity to actually have the tumor analyzed for genetic markers. So if a patient does have these, it's a very simple way to find out what their genes are. And so I like to find out if they have skin tumors for that very reason. These optic, it's interesting, the optic lesions, I say that very broadly, are reported very commonly and were reported commonly. We don't hear so much about them before or now. And the reason I say that is that they say, well, these people have cataracts. But what they really have is it's a lens opacification, not true cataract formation. Now we do know there's some other abnormalities within the eye that we can see with Nf2. But to actually start looking at we actually tried to have our ophthalmologists look at these patients, and they actually found no cataracts in any of our Nf2 patients. And then when we started going back to some of the people who had written about Nf2 back in the 70s and 80s and 90s, and so wait, what happened with this? And they said, well, it was just kind of an opacification. And I think people were using this as a diagnostic criteria when you didn't have good MRI scans. Now in the era of good MRI scans, this really doesn't seem to be a problem. Many of these patients have no visual deficits at all. And so it's something that's in the literature, and I bring it up because it's still widely quoted, but I think it's really not that important. is from my perspective. Spine tumors, I know you all are in otolaryngology and neurotology, but I think you need to really learn about spine tumors. It's actually not that hard. Not that you need to learn how to take them out, but just look at the studies. Here we have an ependymoma. Down here we have a spine lesion. These can be meningiomas. These can be schwannomas. Many times you'll see multiple little rootlets, specifically in the lumbar spine in patients. These little rootlets don't do a whole lot. They just kind of stay there. But again, it's something that needs to be followed. You can also see, here's a cervical schwannoma that's actually on one of the C3 lesions. The Ependymoma, I talked a little bit about this. It's 30% of spine tumors, but again, is it here we are one here. You can actually see the central aspect of it on the axial study. So it's it is a lesion that we see, but it's one that about it. One of the things that's kind of interesting is that in the fovea of the eye, this is optical CT that we did on some of the patients. Normally what you'll see is this type of CT study with the fovea is very thin. What's interesting in a few patients we actually found the fovea, so it's epithelial abnormality or visual abnormality. Now, okay. I note that let's try this. How's that for the video or the audio? Is the audio any better now?
Perfect.
Somebody want to wave to me?
No, that's better.
Okay. So like I said, somebody wave or something. Tommy, thanks for texting me. Okay, other considerations with Nf2 come back is that, we talked about the spinal tumors, genetic counseling, I think is very important, family screening, and then auditory rehabilitation. Indications for testing for Nf2. Testing of Nf2 is not for is only if you already have made a clinical diagnosis of Nf2. So if someone has Nf2 and you want to do the test, that's a wonderful thing. If I've heard people say, well, I think they have Nf2, so therefore I'm not sure if they have Nf2, so let's go ahead and do the test. The problem with that is if you're doing a blood test, it's typically going to be mosaic, and many times they're not going to find that on blood testing. So for that reason, it's just not a good rationale to consider. It's very helpful if you're looking at relatives, as I mentioned, early detection for at-risk individuals. And then if we actually have had a couple of our Nf2 patients who went through prenatal testing to actually with embryo testing and came out with non-Nf2 babies. So, again, there's an option to consider that as well. It's best done, as I mentioned, on the tumor tissue. There's a couple labs that do this. The good news is insurance is usually starting to pay for this now. We have a relationship with the University of Alabama and send all our tumors there for the clinical test. Mass General also does the testing. There may be a couple others, but these are the main two labs that do the clinical test at this point in time. And Alabama's just done a fantastic job, and we've really enjoyed working with them. We just take all of our tumors and send them there. They have a high rate. If you're looking at the tumors, the 70%, if you're looking at founders, it's found in the blood. So again, blood testing is not as sensitive as tumor testing. Now, the problem that we run into with Nf2, as I mentioned, is what happens with these tumors over time. The correlation, we talked some about some of these different correlations. I think the imaging technique's important, and I just put this up. This is a unilateral tumor, and I just put this up because this is a patient who had CT no contrast, CT with contrast, and the MRI scan, just to kind of show the importance of kind of where we've come, especially looking at posterior fossa. I would ask anyone, it's just really difficult to see that no contrast with a CT scan. And here you have a very large tumor. The other thing is small slices are necessary to look at contralateral tumors. So here is just a brain, MRI scan, not very good cuts through the IC. And then thin cuts, you can actually see that there was a tumor. And then I mentioned, so here's a patient who's got bilateral IAC lesions. This patient had melanoma. This patient had breast cancer. So, again, make sure you think about that when you're dealing with, especially someone that's a little bit older that presents with bilateral IAC lesions. Treatment options for NF2. Observation, decompression, hearing preservation, partial tumor removal not recommended because of the fact that the cochlear nerve fibers are, as we showed earlier, kind of interspersed between the tumor. Non-hearing preservation, auditory brainstem implant or cochlear implant, stereotactic radiosurgery, and then drug therapy. This is just kind of my algorithm when I come up with tumors just in general. Big tumors over 3 centimeters, you're usually going to go directly to surgery. Now, this is not necessarily the case in patients with NF2. NF2 patients, they may get quite large, especially if this is their only hearing ear. So that's one of the concerns that we have, with that group of individuals. When we looked at our natural history consortium, and this was 100 patients that were followed for 8 years. And over the 8-year period of time, the question was, why did they have some type of treatment that was instituted? The most common reason for that was that they had growth on the MRI scan, changes in hearing, facial paralysis very small, brainstem compression small, and then a couple just decided that they wanted to move forward with surgery for no other reason. Management of small tumors, of course, we got options of monitoring it if they're stable. And that's probably the most common thing that is done. In fact, most NF2 patients will usually follow up with at least a 6-month MRI scan first before we consider any type of intervention. And so, again, there's a lot of factors that play into that, but that's just something to consider. You've probably all seen this slide. This is the Denmark study that actually showed that over time, the number of tumors under 2 centimeters that are actually monitored. And I think we're seeing the same thing with NF2 now, that this idea that, you should really monitor these individuals before you start to institute a therapy is a very good reason. And this just shows kind of the change of mindset over time. It used to be, oh, you got a tumor, take it out. And now I think we realize that there's some other options to consider. You still see this where people say, oh, you got bilateral tumors, so we should treat you with radiotherapy or treat you with surgery in order to help prevent stuff. But I think we just have to really make sure we look at that conservatively with these individuals. So observation is usually considered. We usually, as I mentioned, do a follow-up MRI scan in 6 months to identify fast-growing tumors. Just as an FYI, last week I had a patient who was 71 years old, 1.5 centimeter tumor, and we did a follow-up MRI scan in 6 months, and boom, doubles in size in 6 months. So you still see these. Fortunately, with NF2, you don't see that as much, although especially the younger the patient, you can see faster growth. I can't prove this, but I have a suspicion that during puberty, many of these kids will have fast growth of their tumor, probably has something to do with hormones, although we never had enough children going through puberty to really say that, but it's just a suspicion that I do have. We do know obviously pregnancy affects growth of acoustic neuromas, so there's some estrogen receptors that can play a role there. Not so much an issue with NF2 because hopefully most of these patients aren't getting pregnant, but I have seen a couple patients with NF2 that present during pregnancy. Obviously, once the growth pattern is established, most of the time that can be very predictive. The other thing that's predictive is we see that individuals who have family members with NF2, the family phenotype tends to be very similar, probably because their genotype's similar. So that's also something that can be somewhat predictable. Obviously, with surgery, we have different surgical options that we can look at, middle fossa, retrosig, or translab. Decompression is something that we consider for patients with NF2. So we had a group of patients that had middle fossa, we'll use middle fossa for decompression. The dura is reflected, but we actually don't remove the tumor. Mike Hope published this paper, and so we looked at the outcome of middle fossa. We looked at, well, how long can we actually monitor these patients? Now, the downside is we didn't have a really good control group, because usually you'll do decompression when somebody's having a significant change in hearing is the most common reason for that. If we look at, though, these patients over time, ultimately they're going to have something done, but there's a small percentage of patients that still had good outcome with good hearing, stable tumor over a 5-year period of time. What we found was that these outcomes tended to be changed based on the size of the tumor. So patients who had larger tumors typically did not do as well as those that had smaller tumors. So smaller tumors, I think decompression is a really good option, but as a tumor gets big, that can they probably don't do as well. Just as a small case report, these are the kind of problems that we'll see many times. This is a patient. She had fainting spells at age 12. She was diagnosed with bilateral acoustics when she was younger. She went around, everybody said, well, let's just observe her for right now. She had normal hearing. This is a case that then, as over a 6-year period of time, she went from small tumors to these size tumors. And this is one of the problems that you run into. So I think you really have to watch these people really closely, because I think most of us would agree this is not a good case from a hearing preservation, whereas when her tumors were small, they were potentially a good option. That was a good option to consider. But once you get to this size, she's kind of stuck into the, try other things and other options to consider. So middle fossa is a good approach for removing the tumors and trying to preserve hearing. In our patient population, we found overall hearing preservation levels. We're able to keep the hearing in 65% of patients. This is a paper we published a while back. Bilateral hearing preservation was actually good. Now, the follow-up to this is that some of these patients do recur, and they recur because they have tumors on their cochlear nerve and facial nerve, and that really is the problem that we'll see, especially in these younger kids, as they have multiple tumors. Hearing preservation rate in Nf2 about 55%, so it's a little bit lower than some of, and this is in the peds population. So we were able to preserve hearing, but that being said, the concern that we have is that some of these individuals will, like I mentioned, develop tumors on other nerves long term. Middle fossa is good for Nf2. Facial nerve results are comparable to non-Nf2 patients. The cochlear nerve, if you preserve it, obviously that's a good reason to consider cochlear implants in these patients if they start to develop tumors that come back. Recurrent tumors, such as facial nerve schwannomas, obviously can occur, and so you still have to follow these patients with routine MRI scans. With any of these patients, also recommend aggressive family screening. If we're going to try to decide which tumor do we go after, if the hearing is equal, we'll usually go after the larger tumor first, as long as that larger tumor is a potential candidate for hearing preservation. If the tumors are equal size, we usually go after the poor hearing first. And then if the hearing preservation is successful, we'll consider then going in at the other side in 6 months. Now, what's interesting is that chemotherapy for Nf2 has really kind of changed the dynamics of the current treatment regimen for many of these patients. There's obviously, patients don't like surgery, patients don't like radiotherapy, and patients don't like chemotherapy, but chemotherapy is a nice option. Because the molecular pathways have been identified, and there's some preclinical work that's been encouraging, chemotherapy has been something that people have kind of jumped on board. So let me just go through a little bit of the history of chemotherapy. So there's a tyrosine kinase. Tyrosine kinase has been identified in Nf2 for some time. There were several studies looking at multiple tyrosine kinase inhibitors showing some potential benefit in Nf2 tumor models. So in 2008, Scott Plotkin, who's an MGH, published the first case report of a patient with a erlotinib, which was a tyrosine kinase inhibitor that was approved for lung cancer, and then he presented his clinical trial. This is the case report. So in the case report, you'll see what happened. This is a patient that you can see that their tumor volume over time was continuing to increase in size on the one side. The left tumor was continuing to grow. Right tumor, not so much. But you can see that once they instituted therapy, that this left-sided tumor did shrink significantly over the treatment time, which was very encouraging. Now, when they looked at then other tumors, the problem that happened is you can see, I think the issue here is if you look at this, those that are having progressive disease, many of them continue with progressive disease. And if we look at, speech discrimination scores, did they really do better? It wasn't real encouraging, and there was some side effects from this treatment. So for that reason, I said, well, is there something else that's available? And so that's where the Avastin trial and use of Avastin has really kind of taken off. So in 2009, Scott Plotkin's, pretty much him and there's Jayshree Blakely, who's at Hopkins, have kind of been leading the way for different treatment trials with Nf2. So Avastin is a VEGF inhibitor. So it's working on the blood vessels. And so what they found is that 9 out of 10 tumors decreased in size, 6 tumors more than 20%. What's interesting is that 4 of the 7 patients in this initial trial demonstrated significant improvement. One of these patients was my patient. She went from 0% discrim to a 96% discrimination in her ear. So she had lost hearing completely, and after 3 months on Avastin, just significant benefit with her. Now, I mentioned here the long-term results are pending because I still think there's questions of this long-term results. As an example, the patient I just mentioned who went from 0 to 96%, ultimately her tumor continued to grow and she lost her hearing. So I think what I see with the Avastin is it's kind of a temporary or temporizing type of treatment. Many of these patients, as they continue, either the thought is that the Avastin inhibits the blood vessels somehow or causes shrinkage of blood vessels, and maybe that's how tumors then shrink because they lost their blood supply. But then as new blood vessels grow in some of these tumors, they actually will have progression of their disease. This is the data from the 2012 Plotkin study. And so, really what you're looking at is if you look at when there's a response, and I think this is important for helping us determine what we're going to tell our Nf2 patients. If you look here, the response is my arrow doesn't go over that far. Sorry, I'm running into the Zoom pictures. But if we look at the response, which is the black triangle, usually it was at 3 months. So patients are either going to have an early response or they're not. So if they have not had a response within 3 months, the likelihood of them having a response is not very good. And I say that because the Avastin's expensive. There's some side effects with it. If they have a good response, so then the other question comes on, well, how long do you keep them on therapy? And that's a real big question that is still, I think, unknown. Here we can see those significant improvement of hearing speech discrimination in these individuals. So it's definitely something that can be very, very helpful. Other chemotherapy agents are being looked at because there's extreme interest from Nf2 patients. The long-term results, as I mentioned, are still kind of out there. There are some current clinical trials looking at studies for Nf2, none of which have really been proved to be that effective. Right now, there's a significant push to look into gene therapy. So there's some work with trying some different trials for gene therapy. We're more in the preclinical stage is where I see that's at right now, and we'll see what happens. So there's intense interest, but right now Avastin is still kind of the staple for treatment of the Nf2 patients. So let's move on now. We'll talk a little bit about auditory brainstem implants. In this lecture, I'm only going to focus on ABI as it applies to patients with Nf2. When I mention ABI, I have a picture of Marilyn Davidson. Marilyn is this lady in the right with a much younger Dr. Slattery. She was the first patient that ever underwent an ABI. Marilyn just recently died at the age of 84 last year, I think. And so what's interesting is 1979, let's just go back for a few minutes. Bill House and Bill Hitzelberger put in the first ABI. There was no FDA at the time. I asked Bill House one time, I said, there was a California had some of the early regulations and they just did it, which was kind of an interesting error of medicine. The other thing that happened is that when they first stimulated the ABI, I recognized this was the first electrical stimulation implant that had ever been put in the brain. So now, we talk about, Parkinson's disease and deep brain stimulators and all this sort of thing. Well, none of that would have been available had it not been for the ABI device. And what's interesting is when I asked Marilyn one time, I said, Marilyn, I said, you're the first person to ever have electrical stimulation of your brainstem. Wasn't that scary? And why did you do this? And she said, well, my mother died of Nf2, my brother died of Nf2, and I figured I was going to die of Nf2. So I figured I might as well try to contribute to science. And if this was going to help me, it was definitely worth the risk. So she had the first implant put in. They was stimulated in the operating room because they weren't sure what was going to happen when they put electrical current across the brainstem. Would her heart stop? Would other things happen? And it was all up to her that allowed everything to move forward. So I think most of us are pretty familiar with the brainstem implant in the sense of it's similar to the cochlear implant. Obviously, this is an old slide because we don't have the power packs for the cochlear implant. It's all the BTE processor now. But this does kind of show the processor with the pad, the current cochlear device on the brainstem and the cochlear nucleus. So the main difference from a regular cochlear implant is that we've got the paddle that has 21 electrodes as opposed to the cochlear electrode. And the Med-El implant is very similar to the cochlear device in this regard. This is a picture of the history of the ABI. So the very first implant that was put in was a 2-ball electrode that you see here. That's what was put on Marilyn. That was followed by a 2-electrode paddle on a Teflon, and then that went to a 3-paddle, 8-channel electrode. Those 4 were, and then an 8-paddle electrode, which is going to follow. These were all the original House ABI devices. And then it was 1993 when Cochlear came about with their device for use in the patients, and the Med-El device followed years later. So here we have placement. The goal of the placement is that we're looking for the lateral recess. Lateral recess landmarks are usually the choroid plexus and the 9th nerve. You can follow that down to find the lateral recess, and then the cochlear nucleus is going to be right in that area. And then fortunately, the other non-auditory structures are somewhat distant away. The current criteria for ABI in Nf2 patients is that you're looking for patients who are 12 years of older. Usually we recommend implantation on the first side. You can do the second side. There was some concern that Gamma knife might be a contraindication. It's something that we have to then, if somebody's had radiotherapy, you have to look to make sure that they actually have a cochlear nucleus, and that cochlear nucleus has not been significantly affected by the radiation therapy. There have been some cases where patients have had different radiation therapy, and the cochlear nucleus was actually damaged as a result of that. So this is a paper that was published looking at our experience from 79 to 2009. There was 242 that had multi-channel implants. 21 were teenagers, and then 10 of this group was also the penetrating electrode device that was tried. What you'll see here is in this next slide, this is looking at Cooney's sentences, that all of these individuals had improvement of their hearing, where basically the ABI enhanced their lip reading skills. So the purple is vision, and then the blue, or the I guess the light blue is vision, and then the purple is actually with the ABI enhancing their lip reading skills with Cooney sentence scores. Now, if you look at a word test over time, this is actually shows that these individuals do improve over time up to 7-8 years later, that we'll see continued improvement over time that these individuals have. So we do see some improvement. So I think we see improvement of lip reading skills. Open set speech happens in these individuals, but it's really in the 10 to 20% of individuals that have open set speech results from the ABI. And so at that point in time, I think we'll, let's see here, stop right here and talk about the ABI. It is very helpful for these individuals. The penetrating ABI, we were hoping it would give some better improvement. There was some benefit with some patients with speech, but not much. So that project has kind of been put on hold for right now. There was some hope that the cochlear nucleus was actually tonotopically defined by depth, and that the penetrating electrode would help provide better tonotopic information, but that unfortunately didn't happen. So I'm going to stop right here and see if anyone has any questions or comments about NF2 and ABIs.
It was a very good talk, Bill. I had a question. Is when you have a family, let's say you identify a patient with NF2, in an individual, and they have family members. You mentioned that the blood test is not particularly helpful. What about scanning some of these children who are asymptomatic?
So I think that is one of the things that we will that we do think is helpful is to scan these individuals. And so if I'm going to scan, so you have someone, you don't have the blood test, they have family members, we'll usually do audiometric tests first, and then just a simple brain IAC study in order to scan them. So some of these individuals, for instance, they'll have children, and they say, what do we do about the kids? Usually want to wait till the child's old enough that they can actually have a nice IAC study. So sometime, if you look at what is the presentation of this individual, if they were presented, say, in their 30s, the likelihood is their child's going to have a similar type disease. So we usually wait till they're maybe somewhere between 9 to 12 years of age before we'll consider scanning them. So now we can see everybody that's here. Other questions or comments?
I have a question, Bill. This is Mia Miller. When you're thinking about middle fossa for either decompression or for tumor removal, how do you make that decision?
So typically the decompression is going to be for individuals that you do not think have a good option for removal. So if you're going to consider, so let's say somebody has IAC lesions on both sides, the ABR, I think, is very helpful at predicting how involved the cochlear nerve is. And so if your ABR, for instance, is flat, it shows, or maybe the tumor is really wedged into the fundus, or it's a little bit bigger than you consider for middle fossa removal, that would be the time that you consider decompression if the hearing is progressing.
Mm-hmm. Okay.
Hey, Bill, it's Ravi Sami from Cincinnati. Great presentation. Thanks for doing that this morning. Question for you. Do you tend to do all your ABIs trans-lab, or have you done any retrosig?
So we have done most of our ABI, well, for NF2, we've done most of our ABIs trans-lab because the tumors have been quite large, and we've done that at the time of tumor removal. For patients who have had, we have a couple of adults who have ABIs for other cochlear reasons, not NF2. Those we've done retrosigmoid. Okay. So you can put it in retrosigmoid. It's not that it can be done. It's not that it can't.
There were a couple of comments. Dr. Coots had said, does a newly diagnosed 70-year-old with bilateral acoustic neuromas have NF2 or bilateral spontaneous tumors? And they seem to behave differently than NF2 tumors, may not grow, respond to radiation, no other tumors or NF2 findings. Oh, you're on mute now.
Yeah. Yeah, something happened. All of a sudden, Zoom went off, and now it's back on. So I missed the question or comment.
I was reading from the comments that Dr. Coots had mentioned, does a 70-year-old patient with bilateral tumors have NF2 or bilateral spontaneous tumors, as they tend to behave differently?
So a 70-year-old with bilateral acoustics? Yeah, I mean, well, so as opposed to unilateral, I think they do are different in the sense that because the NF2 is a germline mutation, if someone is 70 years old and has bilateral acoustics, most likely they've been there for a long, long time. Again, a 70-year-old, the first thing I would be concerned about would be, do they have other reason to have IAC lesions? So you've ruled out cancer in that individual as an example. That'd be another person I'd ask about radiation therapy, previous radiation therapy as a kid. And then if they don't have that, and then you say, well, this is NF2, then I think they're going to be probably very, very slow growing tumors. But then you also have to think about, well, at 70, they usually have kids. And then what are those, where are those kids in their disease progression as well?
Hi, Bill. Steve Tellian from Ann Arbor. Are you aware of a number of active ABI centers around the country where the volumes are fairly high and they're having consistent success outside of your institute?
I guess I don't, but I do in the sense that I think there's other ABI centers. I think the most active one besides ours has been NYU. And I'm not sure what other centers, how active they are. I just don't know. Is there anybody else on the phone that wants to comment about ABIs in their institution?
Yeah, Bill, I can comment. At Cincinnati, Mark Schwartz came out, I'm going to say 5 to 7 years ago. We only do one every 6 to 12 months, so nowhere near the numbers that you've had. There's clearly a learning curve, right? That when Mark, someone like him of his skill set, does it, he makes it look relatively simple and easy. I think the most recent one we did was RetroSig. Great results, but some of these have been hit and miss. It's a little frustrating, as you already know. That's why I was curious about your approach, RetroSig versus TransLab, and if you noticed any difference, because that last one was RetroSig. I felt like the angulation was much better, and we got better result, but that's kind of one.
Yeah, I think we've seen mixed results with both. So I'm not sure that the approach makes the difference. I would say that the neurosurgeon who's involved in the procedure is important because there's some procedures. I remember Hitzelberger talking about this. He'd go out to a new institution to help put an ABI in, and the neurosurgeon was, oh yeah, this is easy. And then when he was there, it went well, and then when they did the next one, again, the neurosurgeon just either didn't get it in the right place, and it takes a long time to make sure you get it in the right place. And I think one of the things we've learned over time when we put the ABI in, and I thought I saw Danielle's name on here. So Danielle is our audiologist that works with us with these ABIs. When you put the ABI in and you're trying to get it in the right position, it's a matter of really working with the monitoring team to make sure that you get good results. But then the other thing that happens, especially with these big tumors, is I think the ABI may move as the brain stem shifts once the tumor is removed. So that's a whole nother issue that potentially may make things difficult with outcome.
Hey, Bill, Walter Coots here. Can you guys hear me okay?
Yeah, we can hear you, Walter.
Okay, good. I was having some issues with the computer. We've been doing ABIs. We had Dr. Hitzelberger come out probably about 11 years ago. We're doing about 2 to 3, maybe up to 4 a year now, just taking a while to build up the practice. And we definitely counsel patients that, our goal is to get some sound awareness, maybe some limited help with speech, reading, and things of that sort. But it's and like you say, I think some of these the brainstem shifts, and then you really just don't have a very good result in some patients. But we typically will place it on the first side if the patient's motivated. So that's kind of been our experience. Pretty limited, but some patients seem to benefit.
Yeah, remember, I think the concern with the ABI is that it's still not clear what separates people who have good results. I mean, we have a couple patients who are, have open set speech. They talk on the phone. They, really do extremely well with their ABI. And then you have some that, as you mentioned, Walt, that you just have sound awareness. And what makes that difference? Bob Shannon used to talk about, well, maybe there's this fovea where there's, a thin layer of nerve tissue on the outside of the cochlear nucleus that may be responsible for that sensitivity. But I remember I had a patient who had a IAC lesion. She lost her hearing, so we put an ABI in. I thought, oh, this is gonna be a great patient, and she just did average. So it's not clear what exactly makes the difference and how well these individuals will do.
Dr. Slattery, I have a question. Can you touch on specifically what type of intraoperative monitoring is done with the paddle and what constitutes good placement? What's a satisfactory result?
Yeah, so when you're looking at the paddle and you put the paddle in, so you have the 21 electrodes across the paddle. What we're trying to find, the problem is that the lateral recess or the cochlear nucleus is curved and your paddle is straight. And so it doesn't fit quite right. That said, if you curve it or bend it, it's not a significant enough curve that makes that much difference. So typically what we shoot for is 3 corners of the paddle having good responses with the nerve telemetry. As we're stimulating each of the electrodes, we're looking at corners. We look across different electrodes. In the middle, each of the corners, and if we get 3 of the 4 corners that have good responses, we usually stop at that point in time. All right, well, any other questions? We're getting close to the 1 hour time, and so I want to be cognizant of everyone's time. I want to thank everyone for participating and for being here, and for the program directors to show up as well. This is fantastic. We thought we'd continue this during the current environment if this works. If people have other speakers that they would be interested in hearing, let us know. I think we're going to have hopefully Bruce next week, followed by a discussion of a synthetic tympanic membrane, and then Craig Buckman the following week, and we'll look for others to participate as well. So thank you very much, everyone.